Don't miss the Narcolepsy Zebras. A 17-year-old female presents with daytime sleepiness that started 5 years ago. She was diagnosed with depression and started on sertraline with no improvement in her symptoms. Falling asleep during classes, study sessions, social gatherings, and meals became routine. She was referred to a sleep specialist.
Sleep testing, involving an overnight polysomnogram and a multiple sleep latency test, were suggestive of narcolepsy without cataplexy,
And she was prescribed a wake-promoting agent. At her follow-up visit, her daytime sleepiness markedly improved and she was performing better in school. Narcolepsy, characterized by excessive daytime sleepiness and sudden sleep onset, affects approximately 1 in 2,000 individuals globally. Type 1 narcolepsy involves cataplexy, sudden muscle weakness triggered by emotions like laughter or surprise, while type 2 narcolepsy lacks cataplexy but still exhibits excessive daytime sleepiness. Narcolepsy is often underrecognized and underdiagnosed.
Proper education of clinicians and the public is crucial to prevent misdiagnosis or underdiagnosis to ensure accurate diagnosis and management,
which can greatly impact daily functioning and quality of life. Classic symptoms of narcolepsy type 1 include the tetrad of excessive daytime sleepiness, cataplexy, or brief and sudden loss of muscle tone, hypnagogic or hypnopompic hallucinations, and sleep paralysis. However, it is important to note that this tetrad is rarely seen in children. The pathophysiology of narcolepsy is thought to result from abnormal immune modulation, genetic predisposition, and abnormal neurotransmitter function involving monoamine and acetylcholine in the pontine reticular activating system. There are two sets of diagnostic criteria. One in the Diagnostic and Statistical Manual of Mental Disorders 5th edition, or the DSM-5, and the second in the American Academy of Sleep Medicine's International Classification of Sleep Disorders, 3rd edition, or ICSD-3. The DSM-5 defines narcolepsy as recurrent episodes of irrepressible need to sleep, lapses into sleep, or napping during the day, occurring at least 3 times per week over the past 3 months. There must also be the presence of one of the following: episodes of cataplexy occurring at least a few times a month, hypocretin deficiency, or rapid eye movement sleep latency less than or equal to 15 minutes, or a mean sleep latency less than or equal to 8 minutes, and 2 or more sleep onset REM periods on sleep testing. The ICSD-3 defines narcolepsy as type 1 in the presence of excessive daytime sleepiness and cataplexy with a positive multiple sleep latency test, or sleepiness plus hypocretin deficiency, while narcolepsy type 2 requires excessive daytime sleepiness and a positive multiple sleep latency test, but no cataplexy. The diagnosis of narcolepsy requires a thorough medical history, followed by a polysomnogram and a multiple sleep latency test. Narcolepsy is treatable. Treatment options include a combination of medications and lifestyle adjustments. Good sleep hygiene and strategic napping are key to managing narcolepsy. Pharmacologic treatments include central nervous stimulants, such as methylphenidate, dextroamphetamine sulfate, methamphetamine, and several others. Treatment options for the excessive daytime sleepiness and cataplexy include sodium oxybate, a low-sodium alternative to sodium oxybate, and pitolisant, a non-scheduled histamine 3 receptor antagonist and inverse agonist. Multiple ongoing clinical trials are underway to add to the narcolepsy medication clinical toolbox. With proper diagnosis and management, patients with narcolepsy can lead productive and meaningful lives. Narcolepsy is a treatable sleep disorder that is underdiagnosed and underrecognized. Studies show that the typical delay in diagnosis is 10 years between onset and diagnosis. Narcolepsy is often misdiagnosed as seizures, fainting spells or syncope, or psychiatric disorders.
Increasing awareness of narcolepsy can have a profound impact on a patient's quality of life. It is crucial that clinicians and patients be aware of symptoms to ensure earlier detection of this very treatable sleep disorder.
For more information on narcolepsy, please see the course resources. For more information on this and other neurologic conditions, please visit aan.com/neurobytes.